We're now going to go on to the proximal humerus, and the talk on proximal humerus is by Leon. I'm going to just mention briefly at the end of it some aspects of osteoporosis and valgus impaction fractures.
I'm going to look at proximal humeral fractures under these headings over the next 10 minutes. The epidemiology for proximal humeral fractures is instructive. They're low-energy injuries. 3 out of 4 occur in women, and the peak age group is traditionally described as over the age of 80. And most of them are undisplaced, with complex fractures being uncommon. And the take-home message from this is, 1, the majority of proximal humeral fractures can be treated non-operatively, and secondly, a proximal humeral fracture is an indicator of underlying osteoporosis. However, the slide on the right is a more recent epidemiology study from Brazil, and this shows a higher incidence in a lower age group, and this may be more relevant for us in the future. The remaining 30% occur in younger patients, and this is a completely different disease. Now, the controversies in proximal humeral fractures is twofold. Which fracture to treat operatively, and what is the appropriate surgical intervention? There is no consensus on this. Traditionally, we use the Neo-Codman classification. The problem is it's inconsistent and unreliable. However, it remains useful as a concept with showing you the four major fragments. Resch has suggested a logical way of assessing these 4 fragments. The first is displacement. The currently agreed that displacement is 5 millimeters or an angulation of 20 degrees. When you look at the head, consider angulation in both the AP and varus and valgus. This is particularly important. As to whether the head is dislocated or split, when considering the tuberosities, consider both displacement and comminution, and at the shaft, you look at displacement. You've also got to consider risk of ischemia. Hertel in 2004 explained that if you have an extension, metaphyseal extension of less than 8 millimeters, which means a more horizontally inclined fracture, you're at risk of ischemia. If the medial hinge is disrupted, more than 2 millimeters, you're at risk of ischemia, and the fracture pattern is important. There's a nice concept of a terrible triad of a medial hinge displacement, short metaphyseal fragment, and fractures of both tuberosities as a terrible triad for humeral head necrosis. Briefly, greater tuberosity fractures. Underestimating greater tuberosity importance and displacement has been described as the worst error made in the treatment of proximal humeral fractures. And the reasons for underestimating a greater tuberosity is firstly visualization. Most of us operate from an anterior approach and the fracture is displaced posteriorly. Second is a failure to reduce appropriately. Understand that the tuberosity is lateral and that the essential reduction maneuver is external rotation. Third, you cannot fix a thin or comminuted fracture with hardware. You require a suture technique through bone. And fourth, and finally, to underestimate the greater tuberosity fractures. Smaller fractures tend to retract over time. Larger undisplaced fractures tend not to. There's less controversy with lesser tuberosity fractures. They occur in younger patients. They're generally displaced. And as a rule, if you can see the lesser tuberosity on fractures, it should be surgically repaired. So there's no controversy with non-operative treatment. All undisplaced fractures, the old or the infirm patient, we treat non-operatively. In addition, there are certain fracture patterns in the older, low-demand patient that heal with minimal complications and acceptable function. This would be valgus-impacted 3 or 4-part fractures, varus-impacted 2-part fractures, and translated surgical neck fractures. But it's important to emphasize that this is when you're dealing with the older, low-demand patient. For young and active patients, the recommended treatment is surgical fixation. And here's the first problem. There is no definition of young, and there's no definition of active. So the ways of fixing it. Well, this is described. These are percutaneous or minimally invasive ways of fixing fractures. It's technically very demanding. And it's probably, if you're going to use it, it's probably best, the best indication is valgus impacted fractures. Intramedullary nailing is probably best indicated for translated two-part fractures. There is no advantage of using intramedullary nailing over lock plating. For most surgeons, locked plating is the preferred method of fixation. And this is, the problem is that we do not have evidence to support this as the exclusively superior technique at this stage. Our understanding of lock plating has undergone an interesting evolution. In 2007, it was referred to as the promising technology for the future. In 2014, it was described as that the evolution in technique had allowed us with locked plating to address a wide fracture spectrum: displaced fractures, angulated fractures, osteoporotic fractures, four-part fracture dislocations, head split fractures, and varus fractures. The 2016 review sounds a word of caution. Contoured lock plate fixation was initially expected to revolutionize patient care and outcome, but more recent studies have shown a complication rate of up to 30%, 1 in 3, and a reoperation rate of 10%, 1 in 10. However, it's not all doom and gloom. Our technique and outcome has also improved with time, and we have recognized two things in particular. First, that varus alignment has the greatest failure rate. And the second, it is particularly important to identify osteoporosis preoperatively, and the patient at risk is probably best defined as the active female in her 50s. There are a variety of things that need to be considered. So at this stage, when using a lock plate, there are a variety of things that you need to consider and utilize when indicated. You've got to consider using a medial fibular strut graft. It's very important to remember your strategically placed inferior calcar screws. And it's particularly important to remember that impaction is acceptable without varus angulation. And finally, you must assess your patients preoperatively, both for the fracture pattern and for osteoporosis. If you consider that your patient has osteoporosis, you need to consider either a bone substitute or allograft bone chips. And the principle is to correct varus malalignment. Hemiarthroplasty. The status of, with the advent of locking plates, the indication for hemiarthroplasty in 2016 has narrowed. And a word of caution, hemiarthroplasty for the treatment of proximal humeral fractures is technically demanding, and in my opinion, probably the most unforgiving method of treating proximal humeral fractures. The typical outcome, poor relief, good pain relief, and poor function is entirely unacceptable in the young active patient. Hemiarthroplasty is particularly relevant, remains particularly relevant in what's described as the high-risk open reduction internal fixation. This is the patient, as described previously, the female in her 50s, who's active, but whose bone stock intraoperatively is identified not to support fixation. And in those patients, the surgeon operating must be prepared to convert, must have the operative flexibility and preparation to convert to hemiarthroplasty. The critical factor in hemiarthroplasty depends on your tuberosity, positioning, and healing. This relates to the height of your implant and having the greater tuberosity heal to the humeral shaft. And the pictures on the pictures on the slide are meant to illustrate the various techniques that must be used intraoperatively, like your pectoralis tendon insertion relationship to height relationship to the top of the head, your suture-specific fixation, and your choice of implant to decide to ensure a better success rate with hemiarthroplasty. Reverse shoulder replacements have become more widely used, and they're indicated for the treatment of 3- and 4-part proximal humeral fractures in elderly patients who have risk factors for poor outcome following hemiarthroplasty. Those risk factors would be tuberosity comminution, osteopenia, rotator cuff deficiency, and age more than 75 years. And reverse arthroplasty has predictably better forward flexion, but requires tuberosity healing to restore rotational function. But there are reasons to be cautious with reverse shoulder arthroplasty. Implant survival is less predictable. There are some studies demonstrating problems with implant survival at 120 months. Reverse shoulder arthroplasty is associated with a unique set of complications. And the published results showing good results on reverse shoulder arthroplasty are from experienced shoulder surgeons. And the problem with reverse shoulder arthroplasty in fractures is that it's associated with a very high early complication rate, steep learning curve, and a very high early complication rate. So, what do we know currently about outcomes with surgical treatment of proximal humeral fractures? These are two studies from the Journal of Shoulder Elbow Surgery and the Journal of Orthopedic Trauma, comparing non-operative treatment with surgical fixation. There are older group of patients above the age of 70, and the basic what they say is that there's no difference in outcome between surgical fixation and non-operative treatment. But to understand these studies, the first exclusion criteria are completely displaced fractures. So the first thing they do is remove from their study group all completely displaced fractures and then compare operative treatment between the two groups. Second, comparing non-operative treatment with hemiarthroplasty. These are, again, studies from shoulder and elbow surgery and clinical orthopedics and related research. Again, showing no difference in shoulder scores and pain scores between non-operative treatment and hemiarthroplasty, but they did show that the hemiarthroplasty group demonstrated significant advantage in quality of life. But again, remember that these studies exclude completely displaced fractures. So the current status is that recent trials have brought into question the advantage of surgery, both hemiarthroplasty and open reduction, over non-operative treatment in patients over the age of 60 years who have 3- and 4-part fractures without dislocation. But the impact of these studies, what they mean over the long term, is not yet established. Finally, looking at reverse shoulder arthroplasty, recent studies in in Bone and Joint and Shoulder and Elbow have shown that at reverse shoulder arthroplasty have a better outcome at 2 years with regard to movement and shoulder scores. And these are in older patients above the age of 70 with 4-part fractures, head fractures, or 3-part fractures with severe comminution of the tuberosity. So our current recommendations would be surgical fixation in physiologically young patients with displacement defined as 5 millimeters, separation at 20 degrees angulation, very serious consideration for fibular strut graft, bone substitute in your inferior head, calcar supporting screws to prevent varus displacement. For physiologically older patients, non-operative treatment should be considered for undisplaced fractures and for 3- and 4-part fractures displaced without complete disruption and dislocation. In physiologically older patients greater than 70 years, reverse arthroplasty has shown advantage over hemiarthroplasty for unreconstructible 3- and 4-part fractures. Thank you.